everyone, and welcome to our July 20th Q&A. We're super excited about our Q&A session today because sometime around midnight last night, Cindy, we got a little special something in the mail, didn't we? Or in our email?
Yes, we did.
The Q&As for the quarter were released last night, those of you that aren't aware, and we have a QR code embedded in our slides today where you can go straight to the link and pull up a copy of the July Q&As. But with me today, obviously, is Cindy Kraft, and I'm Sherry Teague, and we're here to try and answer as many of your home health questions as we possibly can. And Cindy, you ready?
Yes, I am.
Okay, hopefully my list of questions will pull up on the right screen. Okay, we're going to start off with a real hot favorite for Cindy. This one's been around for a while, and it's always something that's hotly contested, particularly in the therapy realm. Can therapists take orders for medications and or give orders to MDs? Also, can therapies actually touch the medication and help with filling medisets? Our corporate did audits and had concerns that therapies cannot be touching meds and taking MD orders or give med orders, only nursing.
Well, this whole issue of therapy and medication, I think we need to take a big step back and calmly look at what's really going on in the home health space, because there's separate issues that have to be handled correctly. We do know that at the time of admission, when there isn't a nurse ordered, a therapist can do that admission, inclusive of collecting the medication information and answering the questions in the OASIS as they relate to that. And in part, that includes being involved with the drug regimen review. So from a compliance perspective, I am able to do any and all of those things that would be part of a comprehensive assessment as deemed qualified to do one by CMS. We do know that doing the drug regimen review is a condition of participation. And as such, we can't get around it regardless of our discipline. But we do know there's been a bit of a wrinkle with respect to the current interpretive guidelines with respect to this issue that talk about the involvement of a nurse in that formal drug regimen review activity. I know we've had this come up on a couple of these Q&As in the past, so I just want to reiterate. If you go and look at the conditions of participation themselves, it doesn't really read that way. It's coming from the interpretive guidelines, and as such, if that's the guidelines given to the surveyor, that is what we have to be prepared to show that we're compliant with. And yes, entities such as APTA and such have tried and are continuing to try to remedy that interpretation issue, but we need to make sure that there is demonstrable nursing involvement in that drug regimen review. That doesn't mean a nurse has to be ordered, doesn't mean that they have to go to the house. It could be done remotely, but we have to show it's being done. I think that piece, Sherry, has caused some other issues to come into play. And the question of, okay, outside of that, I know about that, but what about orders? What about this? Okay, I want us to really think about it in terms of what is any discipline allowed to do. So I would spin it and say, is a nurse allowed to go off script when it comes to the information associated with that medication in terms of when to take it, how often to take it? Well, no, a nurse can't just start wheeling and dealing and saying, oh, take extras or quit that one or don't do this one anymore, because you have to have the physician involved. The physician makes those decisions. And so if a nurse can't do it, I can't do it either. And I would not want to. I have no interest in telling them to take it differently than the most current information that they've been given with the prescription. I can talk within that parameter. So if it says 1 to 2 every 4 hours and 1 doesn't appear to be working, I can reinforce what the bottle says or the prescription says that you can increase that to 2 because that's what it says. I'm not going outside of the lines. As far as touching them and putting them in pill planners, well, I think the issue there, Sherry, is it really a skill to put pills in pill planners? Now, I know we have nurses here and they may be chiming in on the box wanting to, bunk me in the head for just saying that. But I think we all need to acknowledge that physically looking at this is what you take, this is when you're supposed to take it, here's the organizer, I put right pills in right holes. I mean, technically, patients and caregivers can do that. What makes it a skill is if the patient clearly does not understand what they're doing and needs additional support and education around those medications, that if it goes that deep, definitely fall into the scope of nursing. But physically touching them to put them in a box is not in and of itself a skill. And I've seen disciplines like occupational therapy be involved in that act of filling a pill planner with respect to working on the fine motor component or potentially the cognitive component. We may have speech therapists in there on that cognitive element from a different perspective. But this whole, if I can't even touch them, is a bit of an extreme interpretation here. I think therapists, in my kind of wrap up thought on this is I think therapists have a good degree of common sense here to know where that line is. That if I am following what the prescription's given, I'm reinforcing what the prescription says. If I get out there and I'm seeing issues related to this, I'm going to communicate it to the physician, to the nurse, whoever I need to do that. I don't see therapists charging around and saying, I want to play in the pill box. So I think we got to be careful and make sure, yes, we're compliant with this, but that we're very clear that what we're doing is not advanced, complicated med teaching. And if we're in a situation where orders are changing all the time and this needs to be adjusted because it's not working, clearly I think those are situations where nursing would already be involved. Or if we've come in there and there's all kinds of doses changes on Coumadin and this, that, or the other thing, pick up the phone and get a nurse involved.
Yes. And I think that there's some great stuff out there in the industry, written by some really smart therapists about how therapy should address medication in the home. And I think that if you go on to the APTA's home health website or just search therapist medications in the home and you find the sessions that were done by Dee Cornetti and Matt Janes, there was some really good information that was taken out from the home health section of the APTA about responsibilities around meds. And Cindy, you have a kind of line slash joke when it comes to reconciling medications and therapy. Can you tell everyone that joke so we can start off on kind of a funny?
Are you talking about my favorite example?
Yes.
Or about drug classes?
Yes.
Okay. So sometimes I encounter therapists from time to time that are very, very adamant about that they cannot and will not participate in this, that it is well outside their scope. And so my simple reply is, well, then I guess you can't talk about pain medicine anymore. And I think that if we make this about that example as a way to bridge the gap, to ensure what we're doing is compliant, is think about what therapists do with pain medicine. I mean, we're very comfortable telling people, you need to take this before I come, or if it says 1 to 2 and one isn't working, please take 2. You're not taking any of it because you're afraid you're going to be an addict. Well, I'm going to call the doctor and let them know that. You're taking it 2 every 4 hours religiously and it doesn't work. I'm going to call the physician and let them know about this. I'm not going to suggest 3 because that's outside the boundaries of this. So if I'm perfectly comfortable and competent to do it with pain medicine, then the issue is not about my inability to do pain medication management. It's my comfort level with other drug classes. So I think when we look at this and say, well, I'm going to, they just really can't, then you'd also have to say that any discussion they're having with patients about pain medicine also has to stop because it would also be out of scope. And the interesting part about that is therapists sometimes look horrified because they really didn't think about that part. They are doing med reconciliation. They are doing medication management. They are doing teaching within the parameters of the prescription. So if it's really about understanding other drug classes and being comfortable with them, there are tools and resources. There are places to find that level of information to get that comfortable. But there's no way around this issue in a very practical level. No clinician's been in the home, and I would include a home health aide here, that has not gotten a person up and a pill hit the floor. So in that moment, I'm involved with this to some capacity. So I need to understand what those expectations are. And I was using that example once, and a young lady in the front said, when I talked about dropping a pill on the floor, the young lady said, and then the chicken ate it. And I stopped and I said, wait a minute, did you just say? Yes, very deadpan. The chicken ate it. And I'm like, okay, so I have to share this with the larger group. She just said, this is home care, this can happen, blah, blah, blah. But then she followed it up with, and then it died. I'm like, what? It died during the visit. It dropped dead. And I'm thinking, oh my gosh, how are you going to get a patient to take this medication now. I have clear evidence that some living thing just ate it and dropped dead. So I don't really want to take it either. And then I kind of tongue in cheek said, well, what about the missing dose now? Do you have to like quickly eat the chicken to try to get the dose back into you? Home care has its own level of interest. And I still to this day have a little ceramic chicken on my desk in my office to remind me that medication management can have very practical things involved, that we all need to be on the same page.
Okay, as long as we're on medication, Cindy, I have another question about medications. When doing a medication list upon admit or resumption of care, do agencies place all the meds on the discharge medication list on the MAR, or do agencies place just the meds that the patient is currently taking and then follow up with the provider? Some place meds in both the discharge med list and what the patient is currently taking on that initial MAR, but they have to follow up with discrepancies. This has been brought up in several ways to look at, and what do the COPs say to this?
Well, a lot of this goes back to we are supposed to be representing the most accurate list of what the patient is taking. And there are some gray areas there because we can have medications that have been ordered by the physician that the patient is not taking yet. They haven't picked the prescription up. Well, that should be on there. If I have a medication currently ordered and the patient isn't taking it, well, the patient has orders to take that. And so putting it on there and then reconciling that with the physician about if they're never going to take it, then we're going to take it off. I think the issue in the example comes from how confident are we that the discharge paperwork is accurate? Because there are medications on there that the patient is not going to continue with in the home. And so I would look at it and say, especially when you look at the OASIS guidance to item 2001 about clinically significant medication issues, one of the examples they give you to consider is when the discharge list of medications does not match what you actually find them taking in the home. So I think that speaks to, we need to look at this and say, I need the best representation. If there's things on here that are not in the home, I don't see prescriptions waiting to be filled to add them to it. They clearly didn't come over in the discharge process. I'm going to follow up with the provider about should it, but I would personally not be inclined to put every single thing off of a discharge document into my medical record. Because if I'm finding no evidence that they're supposed to continue, I wouldn't put it there. I also would be looking for the fact that there could be some duplicates of sorts, that they were taking one version of this type of medication in the hospital and now they've gone back to their prescription at home and they're really not taking two of these things because a drug regimen review might go ballistic. But what they were really told was to go discontinue these and come back home and take what they were used to. So I would stick with the most accurate representation of what they are actively taking or in the process of taking or ordered to take at home, and then take care of those other things with the provider as needed.
And Cindy, I think that's an accurate perception of what the manual says to do. And anytime you're in a pickle about that, there's opportunities through CMS offers webinars. I know that the intermediaries offer webinars. That's a great question to bring up with them because that's a practical application question. And I think that they should be able to answer that. I am trying to list all the questions that we're asking in the chat so that if you go back and listen to this recording, you have those questions available to you. I erroneously listed question number 2 as question number 5, so just bear with me as I try this new thing to give more information out to folks. So question number 3 is a regulatory question, and it's a super interesting one to me, and I'll let you get the first crack at it, Cindy. In Ohio, can a nurse practitioner be employed by a home health agency and still sign the face-to-face requirement and follow the patient?
Well, first of all, a brief disclaimer. We typically don't address state-specific things in this Q&A. If we have to go back and dig further into Ohio to confirm some of the nuances of that, we're happy to do so. I'm curious what you think about that, Sherry, about being employed by and signing orders.
Okay, I think that there's been some chatter in the past about Stark law violations when it comes to being employed and having a fiduciary relationship with a provider. However, I'm going to echo what you said about going back to the states. First of all, your state would have to be allowing NPs and PAs to sign plan of care orders in order for this to happen in your state. So some states, I think, I'm not sure about Georgia, Cindy, I think it just recently changed, but I know some states are not allowing that at the State Practice Act level. So you first have to be aware if that's going on in your state. Secondly, I had some time to research a little bit on this because this has always been a curiosity to me because it feels like a no-brainer easy button, right? It feels like a, hey, let's find an ARMP that we can afford, and let's take care of some of this egregious paperwork in another way. It's sort of a thinking outside the box way. And what, interestingly enough, what I found was one of the newest providers around Humana's arm of home health, CenterWell. If you go on their website, they have 21 jobs available for ARMPs to do home medicine for home health and homebound patients. They can also do non-homebound patients. There's, a lot of visiting doctors are going to the home. So, but they're not employing them under the CenterWell banner. Does that make sense, Cindy? The CenterWell is the home health agency, but it's also the health system that Humana has created. So they're hiring these ARMPs to be primary care physician or primary care intermediate, what's the word I'm looking for, Cindy? Practitioners in the home to take care of the medical needs of a patient. And that would appear to flow directly into ordering home health and following the plan of care.
Mm-hmm.
So I think that there is a way to do this. There is probably some other, legal minds smarter than me that can give you better guidance on that. But again, start with your State Practice Act and make sure that your ARMPs and PAs can order therapy or order home health. And from that, go to some of the Stark laws and some of the things around that about self-referral. And I would just leave that one there.
Mm-hmm.
But if it is okay, wow. That's all I can say. That's one of those things that you don't want to go to CMS and ask them because you don't want them to get any ideas to write any new rules. If they do not have a rule that addresses this, and they do not have a rule that says no, this may be one of those things that you can do for now. So, any other statements on that, Cindy?
No, I just want to reiterate that with the end of the waivers, as many of our listeners are aware, we do have to go back to what's allowable in our state. And as of the day we're doing this, Georgia still cannot have them sign. And that's been a big sticking point. It was a sticking point during the PHE, but it has not been fixed. So I think some of the things we got used to in the PHE, we just got to make sure that the current rules we went back to don't come into play with decisions. But I commend folks for looking at those out of the box solutions for some of our problems, because I think sometimes we just kind of resign ourselves to, I don't get good communication with my physician, I don't get things signed, I don't get this done, and just kind of what else am I supposed to do? It's worth at least a conversation to say, could something like this work?
Mm-hmm. 100%. And I, like I said, I would go to an attorney, an accountant, someone in that realm versus going to CMS or one of the intermediaries to ask that question. So that's my strong suggestion, that you don't get the regulatory body involved in asking that question. Question number 4, another regulatory question. Are therapists and clinicians required to call the MD after the evaluation is completed to discuss the plan of care? One of our agencies is asking that therapy document that they discuss the plan of care with the doctor, and we wanted to see if this was required. This one came in this week, Cindy, so this is hot off the presses.
But it's an issue that's been around for quite a while, and it seems to be more of a rub to therapy than it's been to nursing. I think nursing has been in a long-standing routine of, I get the order, I go out, I'm going to assess the patient, and I'm going to be contacting the physician about the specifics because you gave me orders, you gave me general direction, you gave me face-to-face, but I'm the one who actually went out and saw this patient. So if I'm seeing inconsistencies about the primary reason for referral, or wait a minute, they have a wound and you didn't say anything about that, the inclination is I'm going to pick up the phone and I'm going to communicate this to the referring physician or designee. For therapy, I think that this is still residual from, some may call them the good old days, where, let's be honest, Sherry, you and I remember when the order for home health just said home health.
Yes.
It never even said what services. It just said do something to keep them away from the doctor and out of the hospital. And even though we were in a much more rigid situation with respect to face trying to remedy that, I think that when therapy is coming in as an additional discipline, so I did not do that start of care, there's still been kind of a prolonged window that if I got a Valen treat, doesn't that cover me?
Mm.
And for a while, we got away with that, like the order that said home health. I mean, it was fine. And I've heard a lot of arguing that I don't think is necessarily wrong, but I hear the frustration of the doctor doesn't really care what the therapist is going to do. The doctor wants to know about medication changes or wound issues, and so they're more interested in what the nurse would say. They don't really care what I'm going to say. Why am I going to waste my time explaining something? They just want me to do therapy. And I think that's true to a certain extent. I think that the physician's ordering it with a you go do your thing. I don't need the specifics from my perspective, but this is an issue of compliance. So when we look at what's required by Medicare about orders and about communication about that plan of care, I think what we've done is said, well, that's the plan of care. The what used to be the 485, that's what they're talking about. But the care plan is a fluid document and no longer is required to be in the 485 format, but the elements have to be there. So I have to be able to engage the physician in terms of, okay, I've done my assessment. Thank you for that order. This is the course I think we need to take. Are we good with it? Now, that also, Sherry, I'm going to try to be brief here, has led to, well, isn't that just I leave a message and tell them, call me back if you don't like what I said? Yeah, we've done a lot of that too, in terms of, not answering me as consent. But let's think about this. What we're doing for therapy is on par as medications and wound care. You can hurt people with therapy. You can do things you shouldn't be doing because of a specific restriction or protocol. There might be information the physician didn't include in the referral about what this patient is safe or able to do. So I have a responsibility to confer that this is what I intend to do and to get any physician insight into, does this fit, not fit, or, do I have all the information I need to safely deliver therapy? So it feels tedious, it feels onerous, it feels like one more thing I have to do, but this really comes down to a patient safety issue and making sure as a therapist I've got the best picture possible of the current condition of my patient so I don't turn around and do something that could end up being harmful.
And Cindy, there is some nuances around some states that have direct access for therapy. There's some nuances around there, but as a Medicare Part A provider, you fall under the Medicare Part A rules, not necessarily the State Practice Act rules about direct access.
Direct access does not apply in Medicare Part A home health, no matter what state you're in.
Exactly,
it does not work.
Eliminates the need for a MD period. Direct access does for community-based and home-based therapy that's outside of Medicare. So just understand that you have to follow those federal rules, your state rules, and your agency plan of care, whichever one is the most strict. And it's pretty clear in the COPs and in Chapter 7 that each discipline has to create a verbal order to provide any type of care outside of what is ordered. And that goes for nurses, that goes for occupational speech, physical therapy, MSW, everybody, you guys. So cover yourself, because you don't want to be sitting on the stand in front of an attorney and having them ask you questions about quote unquote battery. And battery is if you did something to the patient that was not ordered that harmed the patient. That's where you just never want to be. So making that call, however onerous it might be, is something that is super required and super will really cover you as far as the liability issues that can happen in the home. Okay, here is the real question number 5. If you're unable to meet or complete items on the plan of care, should the provider be notified? That being said, when we have a staff member out ill and you try and have another staff member cover, should you still let the doctor know that it's going to be a new staff member, or if the patient says no to that new staff member, we've all been here where a patient has a favorite clinician that they ask for, and that clinician has to be out for a period of time. What do you do besides the missed visit note? How icky is this, Cindy, when these things occur?
Well, it's not ideal, and it should really not be a routine occurrence. But Sherry, as a former agency owner, I'm curious your take on what to do with that when I just don't have the person to get the information.
It's super interesting when you have patients that are on in those situations. My first thought as an agency owner is, why do they need it then? If they're willing to just say, oh, I'll wait till so and so gets back 2 weeks from now, has that been, or a week from now, how necessary is that care? And that's the very first question that would come up in my mind. And then my thought would be, well, if they don't need the care for a week, then why are we going out every week? Does that make sense, Cindy? So,
Uh-huh.
that's my first, because as an agency owner, my first thought was, what was the liability of the agency is staying within those setting guidelines that you have to meet, being homebound, um, uh, needing a skilled servant, I think it says requiring, right, Cindy?
Mm-hmm.
Requiring a skilled service, and for you to simply say, I'm not going to take that service because my person isn't there. Is it required, or is it something that you want? So those kinds of questions, I think, from the management and leadership place, you have to ask, and make super good decisions, and maybe have a case conference on that patient once you have this situation arise.
But I also think, Sherry, something to consider, and I've often looked at this through the lens of what happens in our documentation around a missed visit.
Right.
So this was a planned visit, this was an ordered visit. We're saying it was a medically necessary visit, and the visit did not happen. So whether it was the patient says, I'm waiting for so and so to come back, or which we sometimes see when a clinician's on vacation, or they canceled and we can't get back in there. I think that very next visit has to address documentation in only one of two ways. Either missing that treatment, missing that visit, caused an issue. So it has delayed our plan of care. It has made something less effective. It has delayed what we were going to be doing, because if it was truly necessary, there is a negative impact to not having it. Because then the other way is, if there's no harm, no foul, then I have to reevaluate my plan of care in terms of, is this really necessary? So I think what I see from a documentation standpoint is any missed visit, it just seems to be followed by a next visit that doesn't mention anything happened, that a visit was missed, and just picks up like this is no big deal. And I look at it and say, if you had recommended that something occur 3 times a week, and last week, 1 time a week is all they got, and everything was fine, what makes you think you get to go back 3 times this week? Because you're not making that case. So I think it's about looking at it and saying, on a bigger picture, if something is missed, regardless of reason, I need to be confident enough to say, what was this impact on our plan of care? And if there absolutely was none, I need to reevaluate what I'm doing.
100%. And I think that we need to look at that. And I think that the way that folks are doling out their visits, or their in-person visits, I should say, because I hate the word visit anymore, Cindy. As you know,
Oh, I know.
it's a stickler for me, because we don't get paid for visits. We get paid for care, except in the instance of a LUPA. And the LUPA is, determinant on which bucket they're in and what their diagnosis in. There's a lot of machinations that are going into a LUPA anymore, but it feels to Cindy and I like care is being rationed in home health, for some sort of a profit goal. And that, that happens in home health. And I just want to be really clear to folks that if you're going to have this many missed visits, and then you end up seeing those visits when the clinician gets back, and it puts you just above a LUPA level, wow, that's risky. Because that is ripe for the picking. Is that a fair thing to say, Cindy?
Yeah, because that's what we're seeing, folks that are getting ADRs, folks that are ending up in TPE. There definitely seems to be some focus on the near miss of a LUPA. And to your point, we're not saying, the patient wasn't seen for a week and we went twice more just to avoid a LUPA. but even it occurring incidentally can put you in a number that makes people question it. And so we just want to make sure that folks are documenting as accurately as possible and making sure that we're able to defend that care. Because you're right, if those last 2 visits just after that week off were the final 2 visits that just avoided a LUPA, you could see where they'd be motivated to say, well, they did fine that whole week. Why were you still there? And I would just add, oh, go ahead, Sherry.
No, you finish.
No, the one thing I also wanted to just throw in there is the frequency and duration issue, also about what patients need. I always kind of question, yeah, we're compliant that it's twice a week, but then you start looking at a calendar and it was Thursday, Monday, Tuesday of one week, and then next week it was Thursday, Friday of that week. So technically, I hit my twice a week order and there's nothing I need to notify the physician about. But I look at it practically and say, wait a minute, there was over a week in between those visits. So are we dosing this because that's how this fits the needs of the patient? Or was I going to take a few days off and this was the easiest way to move it around? Or whatever the other reason is. But I think we need to be thoughtful about this idea of what they need and how we dose it, because that can come into play when we're trying to defend medical necessity.
And in the case of therapy, Cindy, the reassessment requirement says that a reassessment has to be done at least every 30 days. So in the case of a patient that missed therapy visits because a clinician was out of town and you're not 100% sure that they don't qualify for home health, I highly recommend that first visit back from their wanted clinician is a reevaluation and a reassessment. Because then that way, if you do get an audit, they see something that's directly reflective and addresses the missing visits prior to that and what the need going forward is. If you don't have that, they may come in and pick off those last couple of visits after the break and leave you in the LUPA situation anyway. So a way to kind of cover yourself would be to maybe do a reassessment visit early and then reset your 30-day clock to do the next reassessment. Do you have anything to add to that, Cindy, before we move on?
I just think it's a great example of that reassessment. The issue is only it can't be more than 30 days between them, but strategically using them for the example you just gave. I also say we should consider them if a PTA or an OTA is executing this plan of care and is noticing this is not going as we expected, or maybe they're doing better than we thought and these goals need to be advanced, or maybe this needs to be transitioned to maintenance. You really don't want them just kind of going through the motions to get to the next scheduled 30-day reassessment. They need to be able to say, hey, hold on, I need this to get scheduled because this is what I'm seeing, so that we can get a plan of care change timely or a transition to maintenance done timely, and not wait around potentially generating visits that look like they're ineffective visit after visit until then, which also opens us up to partial denials by saying this really part here wasn't doing anything.
And Cindy, I'm going to add another recommendation that we gave a client recently, and we've blasted it out on social media a little bit, but I want to make sure that the group that's here today has the opportunity to hear it. We are highly recommending that a reassessment or a reevaluation be done before the first visit in the second 30 days as well. Not required, not required. However, we're seeing a lot of audit activity that is picking off visits in the second 30 days as being not medically necessary due to they don't have, if you do that 30-day assessment in the first 30 days, when they pull the ADR, they're pulling it for the date starting with the first day of the second 30 days. And if they do not have that information in the second 30 days, they're denying based on need.
That's, and we don't want to turn it, because I know we have more questions, but I think the takeaway there is that the 30-day reassessment lines up very closely with the 30-day payment periods now. And not only are we seeing a focus on those near LUPAs, we're seeing consistent denials of saying that the therapy that went into the next 30 days was not well defended. And this feels like on some level, and I apologize if I annoy some people, but from a K&K perspective, this feels like a big I told you so. because those therapy reassessments have been around since 2011. And I think we've been very, very focused as an industry on the timing compliance and what we labeled it and how we scheduled it. But what we're seeing is denials because the reassessment, although done on time, did not contain a subsequent objective measurements. It doesn't say you have to do all this tests all over again. They want to see objective information and they want to see why you think additional therapy is warranted. So continue per POC, continue per physician order is insufficient. I have to say, in my professional opinion, based on what I've collected, this is why additional care and this is what we're going to do. Because without that strong of a statement, we're out of compliance with what the reassessment is. And then they're just having a field day, no matter what the level of content in the therapy individual visit notes in the second 30-day, they're denying it outright. So you can have magnificent documentation in that second 30-day, but the reassessment didn't meet expectation and they are well within their rights. And that is not going well at all with respect to appeals, to just chuck it.
Mhm. So that's just a little piece of advice that we've learned on the road. And Cindy, I wanted to remind everyone that they have the opportunity to ask questions, and we'll get to as many as we can. But we do have a hot button issue, and I wanted to remind everyone to put that in the chat or the Q&A, because I'm about to hit you with a GG question, and I hope that we don't go until 4 o'clock this afternoon. So
I'll be good.
Okay, here we go. Question number 6. If I have clinicians that have been taught that they only have to answer one GG goal and can answer not answered for the rest of them, am I correct when I say no, you have to assess and set goals for all the GG questions that can be assessed? So I opened up, for our listeners, I have opened up a GG door. And that door is kind of like the portal to the down under. There's some new information that Cindy's about to share that's in our podcast that's on YouTube. Explained a whole lot more in detail than what it'll be explained today, but just suffice to say the GGs have just become super important.
Well, I'm an Oasis purist. I believe every item, every time point, every time we have to know what the official guidance is, and we have to provide the best possible answer from the options that we're given. But unfortunately, when we have, limited time and dime resources, we can become focused on prioritizing them in some capacity. So the 1800s have had their days in the glory for what feels like forever, because the 1800s assessment of function has been part of our reimbursement. It is what drives compare scores. It makes us get stars or not the stars we think we should get. So they have their day in the sun, and their day is not going anywhere. But GGs are about to go from oh, are those really relevant? Or can't I just put a couple goals on this thing, to front and center potentially in value-based purchasing. So let's deal with the question first and then kind of elaborate a bit. Yeah, you can argue that back in ye old days, when we started with the GGs, there was discussion about, what's required. Do I have to? And at the time, initially, we have to understand what they've been doing with them is just collecting data that we had to report. And so what they said was we needed to report a goal on at least a couple. Okay. But as we move past that, it became, why would I only put goals for at least a couple? Well, I think part of it is we get uncomfortable with the goals column, because it feels like if I put that, then I have to have goals on my plan of care that say that and all this other rigmarole. It really was never about these are goals in the traditional sense. Remember, discipline neutral data collection, not a clinical document. It was really just a projection of what we reasonably thought this person was going to be capable of. So if I think they're going to be better than now, I can put that. I think they're going to be the same, or maybe we're working towards staying the same and stabilizing function through a maintenance program, then that number should be the same as what I see today. And if I reasonably think the patient's going to decline, then that's what I'm going to put. Because what I'm saying is, CMS, this is what I think will happen. Unfortunately, between the initial minimal use of the goals and then what we see now, which is robust completion of the goals, the problem is the goals now have some challenges. I very often, when I get into OASIS records, see that every single one of them is a 6 at discharge. Really? Okay, that can happen for some patients, not every patient. And that's not realistic, because are you communicating to CMS that you think you're going to fix all of this. Because if I'm saying we're going to get to 6, then I would assume that's exactly what you intend to deliver. So we've run into some accuracy issues. Um, what I would suggest is we are use the goals as intended to say, let's be reasonable in our projection. Let's be comfortable and confident as the assessing clinician in collaboration with others as needed to say, let's be realistic about what we think this patient's going to be. Where do we find ourselves now? Well, I know the proposed rule came out right before the 4th of July. I swear they love Fridays before major holidays. As I told Sherry, I think they hit the, release button and then they all flee the building. So no one can bombard them with questions initially. But I know, and I get it, that the initial reaction to the proposed rule is always going to be about payment reductions. Are we getting them? How bad are they? What are we going to do about it? Absolutely important. But sometimes what gets buried in that are other things within those proposed rules. And one that I'm not hearing a lot of discussion of yet has to do with value-based purchasing. So what they want to do is for the calculation related to OASIS. So we know for value-based purchasing, 35% comes from OASIS, 35 from claims, and the remaining 30 comes from patient satisfaction scores. It's still going to stay that way, but they are proposing to completely jettison the 1800s out of the calculation, all of them. So the assessment of function, although it's a composite score in value-based purchasing, would be no more. They want it gone. What they want to replace it with are GG items. Not all of them, a subset. And as Sherry said, we did a podcast on that this week, so there's more detail in that. And we fully expect as this moves forward that K&K is going to develop additional longer educational sessions, not terribly long, but give us adequate time to discuss it, and resources related to this. It's a short set of them because they have chosen to utilize the GGs that are also currently in use in skilled nursing facility, inpatient rehab, and long-term acute care hospitals. So when you look at the list of the GG, you would expect the heavy hitters we've come to know and love: bathing and upper body dressing and lower body dressing and ambulation of 150 feet and use of stairs and picking things off floors. Yeah, none of them are in there directly because LTACs, their GG set excluded those. They don't have data on those. They don't answer those. And I understand why that works for an LTAC. That doesn't really help us out much because now what we see, it's about eating and oral hygiene and rolling, ambulation to 10 feet, 50 feet in 2 turns. It's a short list. But the issue then is, oh, okay, so they're going to measure our improvement in those. Yeah, but not the way we're used to. So what they're going to do, short version, is calculate the baseline score based on how you've answered for those items. And then they're going to do some special Medicare math through risk adjustment to predict what this patient will be capable of at discharge. And the measure that will go into value-based purchasing is how close to that prediction do we get? Are we at that level or exceeding that level? In other words, if we stayed the same as what they predicted, if we stayed the same, we're good. If they got better than that, that's good. They're really trying to create a model, one, that we can't game. We're not going to be able, because this is going to come off of looking at our discharge answers versus this predictive model. So I can't get in there and just say, oh, if I put it as a 3 at the start, I'll just put it as a 6 as discharge. And oh, look, they improved. Nope, they want a way that isn't gameable. They also want to make sure that this finally accounts for staying the same and getting better are both positive patient outcomes. So really the only thing that kind of works against you is a decline. But yes, thank you, Sherry. It's about time that some of our outcome measures actually consider that stabilizing the home health patient's function is valuable. But the risk adjustment comes from a ton of other things in OASIS, looking at their age, looking at their access to caregivers, looking at, and Sherry gets excited, diagnosis coding, their comorbidities, surgical diagnoses. Have they recently had surgery? I mean, there's a whole list. And Sherry, I think we could also add to this when you post it up, the link to the document with respect to some of that information that was buried in the proposed rule that outlines how this math will work. If you're secretly a statistics junkie, you'll love all the details and the pretty math pictures, and you can tell I can't even use the right words. I'm not that jazzed about statistics. I just want to make sure that what we understand, even if you look at it and go, this is mind-boggling, this is ridiculous, I'm going to retire. I quit. I'm not doing this anymore. The bottom line is simple. We're back to every item, follow the guidance, best possible answer. Because when we do that, and that's what CMS is assuming we're doing. That's why the whole, oh, they can't do that now. Oh, they can't. They've been collecting GG data on us since 2019. And they went into it assuming we were following the guidance and answering all the questions correctly. So to now say, no, we weren't paying that much attention, or no, we didn't really review those, or no, yeah, we didn't really pay too much. That's not going to fly. They have the data. They assume we knew what we were doing, and so they're simply overlaying this model on it. So we got to make sure that our GG house is in order, that people are not willy-nilly and sticking the non-applicable codes on there, that you're really looking at the full scope of how it says you can assess. There's interview, there's demo, there's discussion with other disciplines. There's a wide variety of things the guidance manual says we can consider to choose an answer before we go to the non-applicable. But we want to make sure it's accurate. So back to the goals thing, Sherry, what was also a single line statement that even I missed when I first looked at it. The next update to OASIS is going to remove the goals column completely from GG 0130 and 170. And I'm a little sad because in my naive brain, that would have been our opportunity to have a say in what we believe is the outcome, that we're projecting improvement in some areas, stabilization in others, and potentially decline in a few. But I believe that they've looked at that data and deemed it to be not useful. I mean, if everybody's going to be a 6 or everybody's going to be a this, or they didn't get complete data from some that didn't fill one for all of it, I think it rendered it useless from their opinion. And they're just going to tell you don't have to collect it anymore. Now, that doesn't mean I can immediately stop the goals. I'm not under the new rules yet. It's still a proposed issue, and they would start looking at claims effective January 1, 2024 at discharge to create the baseline data for 2025 value-based purchasing. But it just speaks volumes that no matter what the OASIS question is, we have to understand and follow the guidance, and we have to be confident that those that are reviewing the work are doing so correctly, that they're utilizing the most current Q&As, that they are not adding interpretations that are outside the boundaries of the official guidance. My little soapbox on the side here, Sherry, is I think this focus on outcomes and value-based purchasing, we're starting to see review processes try to, as you so often say, round the corners on the box and come up with things like, oh, well, you know, those items in the 1800s that talk about majority of task. Well, that really means that if the patient needs help with the majority of task, they're dependent. I haven't read that anywhere in the guidance or the Q&As. So now you're all of a sudden going from your patients who were baselined appropriately as 2s and 3s, and now they're all 4s and 6s. This manifests itself in the beginning part of the proposed rule that talks about how they're going to have to reconfigure the point system again for function because people somehow keep getting worse and worse, which, oh my gosh, I didn't even think was possible with limited response options. But we got to make sure data integrity is there, because we don't need to feed CMS any more information that makes them think that we're gaming the system.
And many of our listeners are using data mining companies to determine their utilizations and their patients that they're going to take on service. And this is just CMS using data to do the opposite, to figure out where we mess up, to figure out where we're not giving them the correct information, and to, you know, plan their changes accordingly. And for those of you that are out there in a full GG panic right now, after that little bit of information, don't worry. We actually dropped this slide that I have up right now. We actually dropped this product the day after I think the proposed rule came out. And it actually has the M items and the GG items. And the purpose of these quarterly three-part things that we're doing, we've done the second quarter, which included the BIMS and the PHQ 2 to 9, Cindy.
Yep.
And now we have the one on function, and they're $129 per agency. It is a no-brainer. They come as MP4s. You put them into your LMR, and they are designed for the clinicians. Cindy and I are big believers in if you train your front line, it's going to improve your bottom line. Getting accurate data collected at the patient, that the patient looks exactly like what it does in the documentation, is so important. And so these little 20 to 30 minute webinars can be viewed or listened to in the car. And they're actually just guidance on how to collect that data appropriately from the patient. So super, I mean, we love these products that we've made. So I just wanted everybody to know that this would help with collecting the GG data. It is appropriate. We went back and looked at it to make sure, since this was in the proposed rule, that it is appropriate and how to do that. So that's on there. And the other thing is to just do a simple quick OASIS audit to look at your GG items. We have products out for that. If you want to reach out to us about that, you're welcome to, but there are a lot of folks that do this. And I suggest that you get something or have an internal person do a GG audit to see where you stand. Super, super important. And I mentioned earlier that the July OASIS Q&As were out. If you take your phone out right now, go to your camera app, this will take you directly to that, and it's the form with all the changes. This one Cindy described as a little bit benign. It wasn't as exciting, so we haven't really talked about a whole lot of it on this session because I think it's pretty straightforward. And if you have any questions, you can always reach out to us at our emails that are provided here and or at www.valuebeyondthevisit.com. Cindy, we have one more question.
Oh, can I mention though, there was two little things in the Q&As that I found interesting.
What's that?
They weren't earth shattering. One has to do with what do you do when a patient is referred to you that has been recently discharged from a hospital at home program?
Ooh.
And I'm like, well, so you're talking a formal hospital at home. That patient has been managed in the home by an acute care hospital. The response was if they were discharged from that program in the last 14 days, then it's reported in the OASIS as an inpatient facility discharge.
Ah.
The other one, because if anyone's listened to me before, I try to find the humor in OASIS whenever possible. It's not necessarily humorous for the patient, but someone actually asked, because they must have encountered it. That's what I like about the Q&As once we get into real OASIS-y. But how do you answer the CAM when you're talking about their level of alertness and that kind of thing when they're comatose?
Exactly.
Well, no, that's the question. And CMS actually did respond exactly how to respond to the different components of the CAM assessment when your patient is in fact comatose. I thought that one was interesting. Again, I wouldn't expect it to occur very often, but it is something if we ever run into it, they've given us specifics. But everything else, fairly benign. I'm surprised there wasn't anything more about the beloved high-risk use and indication question, but we'll see what happens in the next quarter.
Okay, Cindy, I have one other question before I go to our last question. Where can an agency obtain guidance on what should be done on a 30-day reassessment and how this should be documented? Where's the best resource for that? Off the top of your head. See, I know she has one, guys, so
what needs to be in the therapy reassessment?
yes.
It's going to be awkward. I'm terrible at tooting our own horn, but I'd say K&K.
Yeah.
Because we've been talking about this since the very beginning. And if you go to the official guidance about it, it does reference objective measure and speak to effectiveness. It's more conceptual and not necessarily step by step by step. But really what you're looking for in that reassessment is clear understanding of why this person needs continued care. And I believe even on an internal level, and it doesn't have to be a therapist to a therapist. If you're a nurse in the organization, you work in QA, and you just honestly read a reassessment, is it making a case supported by objective information as to why you should pay for additional skilled care?
Right.
And if it's just kind of, I'm going to keep trying what I was doing and I can't really tell if it worked, or It can even say it hasn't been effective to this point, and I'm going to change the plan in this direction. I mean, the official guidance says that if the therapy has not been effective to this point, you can continue, but you're going to have to say what you're going to do about that or when you expect these changes to occur. So you should be seeing a lot of thought-driven clinical decision making in that document, not just you could walk 10 feet before, now you can walk 20 feet. I want you to walk 30 feet, continue PT. If that's what you're seeing, there's a problem.
Yep. And it has to be relayed back to the function of the patient and how they're improving, or how you have to change the plan of care or change your interventions to get them to the place that you need them to go. Reach out to us by email and we'll get you some information and get you the link to the guidance and that kind of thing. So definitely reach out to us. Okay. Last question. 4 minutes. Cindy, you ready?
Yep.
Okay, we are getting mixed information about whether it is appropriate to take pictures of wounds on personal or documentation devices. Is this allowed? Also, what are the general rules around taking pics of wounds?
Okay. It's interesting because I was working on a presentation with a colleague earlier this week, and we were talking about wounds and documentation and all of that. And I posed the question about wound pictures in terms of, is it really, I've seen wound pictures enhance documentation. I've also seen it mess with it. Is probably the nicest way I can put it. If we're going to be utilizing wound pictures, let's deal with that piece first. So how we get them aside for a second. If wound pictures are the path we're going to take or we are taking, there absolutely have to be written procedures about how those pictures are taken in terms of how we're, putting down landmarks, what we're putting safely by that wound to be able to judge size, lighting expectations, how frequently you expect this to be done. Because what I've been encountering is without that, these pictures are not helpful. You can't tell what the orientation is. You can't tell picture to picture. They clearly weren't taking it from the same vantage point. So maybe it's the same wound, but I can't judge this well because it's kind of all over the place. The lights aren't all the way turned up, so I can't quite see it. I've seen some where the clinician's finger is in the picture with the wound, not as a reference point, just finger in the lens of the picture. As you can imagine, you go, well, this is really not speaking to skilled care if I'm looking at somebody's finger. Because I imagine if you took family pictures or pictures of your friends, you would make sure there was adequate lighting and you could see everything and all that good stuff. So procedures around this and ensuring people are following those through the supervisory visit process are very important. Also, even the best taken picture does not substitute for actual wound documentation. That was the question I posed to this individual, is taking, because you got to make sure you got the measurements and the depth and all that, all the good stuff, but can I just drop a picture in my record and say, boom, I've covered the wound? And their response was, well, there's definitely elements of that wound that are not captured in the picture. Now you can tell real quick, I was talking to a nurse because she started talking about odor and how you can sniff it and it's Pseudomonas. And I'm like, oh my gosh, this is why you do not see RN after my name. Nope, nope, nope. I do not want to be sniffing these things. But to her point, it doesn't capture everything. And so you want to make sure you have a procedure in place. People are following that procedure. These are viable, useful pictures. But then I'm also seeing the rest of that documentation, because taking a picture is not a discipline specific skill. Knowing what I saw, knowing what we're doing about it, my professional opinion about the status of this wound, what might need to change about the wound care to get us where we need to be, that is all where the skill lies. And a picture doesn't substitute for that. As far as taking the pictures, Sherry, as a former agency owner, I'd love your input there. I've seen it be very rigid about the device that's being used. I've also seen folks say, well, if I don't have any patient identifiers on it, I'm completely fine with my clinicians using their phones. So what are your thoughts?
Well, very quickly, I think that having a policy around this is super, super important. The guidance does not say whether or not you can use a personal device or a documentation agency issued device, if you will. Part of the policy should say something about deleting the pictures permanently off whatever device is used. But having that guidance in your home policies is super important to CYA to cover your you know what. So having that and making sure that it's not more stringent than the federal and the state guidelines are super important. Cindy, wanted to mention real quick before we take off is our next Q&A is scheduled for September 21st at 1 p.m. and we'll be sending out that link with the recording of this session, and we just love your input on the questions ahead of time. That helps keep us focused and helps us make sure that we're meeting y'all's needs on this session. Cindy, did you have any final thoughts?
No, I just wanted to wish everyone a good summer. I know a good part of the country is cooking right now with the heat, and that makes home health even more challenging, especially when some of our seniors don't seem to think it's that hot or have different strategies that don't necessarily work that well. But I just want to send positive thoughts to all the clinicians and those that support them, trying to navigate some of this interesting weather we're now seeing this particular summer.
And hence my picture on our Q&A. I'm in Florida and we are definitely baking down here pretty heavily. And so be careful out there, make sure you hydrate, and we'll see you in a couple months. And thank you so much for being a loyal listener, and we appreciate you and hope you have a great summer.